Welcome back to Navigating Cancer. I'm Dr. Joey Bennett along with Wendy Hall. We are both at the Robert Boys Oncology Institute located in the Allen Ridge Medical Complex in Lecanto. Today we're talking about pain, and we're focusing on pain specifically from a cancer standpoint. The first two segments we talked a lot about it, the pain and how to assess it, but what I want to spend the last segment today is talking about how we manage it. And when you look at the pharmacologic management, there is a ladder called the WHO ladder. It's the World Health Organization ladder of how you treat patients. And you start out with analgesics that are not opioid type analgesics, Tylenol, Advil. You can then move into adding narcotics plus these other drugs, sometimes adding antidepressants, sometimes adding nerve blocking type drugs. So there's a nice little ladder that you can follow, and this next slide kind of shows how it works. At the bottom of the ladder, if it's mild to moderate pain, you want to start out with aspirin, kind of the non-opioid type things that you run into. If the pain is worse, then you want to add some of the opioids, and what we're talking about here is codeine, hydrocodone, and things of that nature. And if you're looking at someone who's going to need long-term assistance, you're going to probably end up moving up with severe pain to the stronger opioids. And here we're talking about morphine, which I think is one of the most wonderful drugs in the world because it's pure and works very well. Oxycodone is another one that a lot of you have heard a lot about because of abuse of OxyContin, a specific type of drug. So the first thing we do is we go into the non-opioids, and this is the non-steroidals like Advil and like Aleve, acetaminophen, which is Tylenol. You can utilize some topical creams as well, but you have to realize that these types of things are really best for mild pain. There is a ceiling of what they're going to be able to do for you. You always start at the lowest effective dose that you can possibly use, and at the same time you want to make sure you're looking at the patient's medical history. If that does not work by itself, we can then start adding some other things here that are not necessarily narcotics. There are antidepressants that can help, sometimes seizure medications can help, steroids like prednisone and dexamethasone can help, sometimes muscle relaxing agents. So you can see there are a lot of different things on this slide that you can choose to add. Plus we can use drugs that actually help make the bones stronger. We can use steroids as I talked about beforehand, but again, you have to choose these drugs carefully because they all have side effects. You start low, you gradually build yourself up on them, and you don't want to stack too many things in there all at once, because if you take somebody who is on one medication and then all of a sudden you throw two other medications on there and they're better, did you really need both of those? Could you have gotten by with just one? So it's a slow, stepwise process, trying to get someone as comfortable as fast as you can, but also doing it at a reasonable pace so that the next thing you don't know, you're on 5 or 6 different medications, and we have a lot of patients like that.
So I have a question. When you're moving up the ladder, is that mainly because the patient's pain is worsening, or is there tolerance or something like that? Or?
Well, I mean, it's a combination of both. It could be that their pain is getting worse, but sometimes if they tell you they have this pain, you try something simple first, and if it's enough, you stop. If it's not, you add more to it. Mm-hmm. You can have someone's pain get worse. Tolerance is not necessarily something that we see that often. I mean, you really don't become tolerant to these medications. If they quit working, it's typically because the pain is worse, or you're just not absorbing the medication in the way you're supposed to. The next step going up the ladder is moving into the opioids, and these are the drugs like codeine, oxycodone, hydrocodone, and step 3 is moving up to those stronger ones that I talked about. We use a lot of oxycodone and morphine. Fentanyl is the drug that is in the pain patch that a lot of you have probably heard about before. Methadone and Dilaudid are drugs that aren't necessarily used a lot by physicians that are not treating cancer-related pain, but for those of us who treat a lot of cancer-related pain, the Dilaudid and the Methadone are actually very good drugs, and we try to pick these drugs so that they're pure and clean, because way too often drugs like Percocet have more Tylenol in them than they do the narcotic. And the Tylenol is not necessarily that effective for the pain, but too much Tylenol will absolutely destroy a person's liver. So it's nice to be able to use something like morphine or oxycodone because they're pure, clean drugs, and there literally is not a ceiling. There's not a maximum amount of dose that you can give someone. And if you need more, you just give more and slowly titrate them up on it. So to me, the way I look at opioids in my practice is I use these for patients that I think are going to have some long-term or chronic pain. I like to use some of the long-acting drugs, but I usually give them something that's also a quick-acting one as well. And one of the things you have to look at is the financial situation of the patient that you're talking to, because some of these drugs can literally cost hundreds and hundreds of dollars a month, whereas some of the generic narcotics that are out there are much cheaper. So OxyContin, for example, is a great drug, but it's very expensive. And sometimes people just cannot afford that. So we look at other ways to manage their pain effectively and try to be cost conscious about that. I usually don't try to change the narcotics, as I'll show you on this next slide, unless a person's having real bad side effects or can't swallow anymore, or the cost is just really, really high for them. So we usually try to find something that works, because once you get the pain under control, you're used to using that drug. And here are the side effects we talked about beforehand. When you start switching around, they can be worse, but constipation, a dry mouth, a lot of people have nausea related to codeine. The sedation, being sleepy, is a normal thing that tends to get better. Occasionally you'll see people tell me that their dreams and hallucinations are unbelievable. The respiratory depression that you see on here is typically by giving a little bit too much narcotic to someone. Finally, as we talk about this, there are other ways of managing pain, and here are some of those that are listed. There have been studies that have shown acupuncture can help, yoga can help, guided imagery about what is causing your pain, sometimes a cold pack or a heat pack, massages can be beneficial, TENS units are the electronic units that people use a lot of times if they have bad backs and such. Counseling, like Wendy and I talked about, helping patients deal with their pain, and exercise programs. Unless you've got some real risk of fracturing a bone or hurting yourself, the more active, the more agile you are, the better you're going to feel. And especially when you start talking about bone pain often, the more you can move around, the better you feel. So
are you going to talk about on another show about radiation for pain management?
We are going to go into that as well. I mean, there are lots of other avenues for pain management. We do radiation very often to relieve the pain when it's related to tumors, and there are spinal cord stimulators and pumps, and like I say, in a future date we're going to have Dr. Mark Hashem talk about that, and we'll go into that deeper. Thank you very much for joining us today on Navigating Cancer.